We'll give it a minute to allow everyone to join us. Welcome to the ALS Learning Series. Okay, well, I'll get started. Welcome everyone to the Les Turner ALS Foundation's April's Learning Series on Advanced Directives. Before we begin our webinar today, I wanted you to know that you're muted and you're not on camera. So just sit back and learn a little bit more about this topic. You'll notice that we have a chat box in the right hand of your screen for you to enter your questions to be able to ask questions for the presenters. And lastly, this is being recorded, so you'll be able to view it on our website in the next few days. We'll get that up. Welcome everyone, and let's get started. So I'm Lauren Webb. I'm the Chief Advocacy and Outreach Officer for the Les Turner ALS Foundation. Before we get started with the presenters, I just wanted to tell you a little bit about the foundation. Okay. The Les Turner ALS Learning Series is made possible by a grant from the Gilbert and Jacqueline Fern Foundation and Mitsubishi Tanabe Pharma America and other supporters of the foundation. So I wanted to take a moment, and I'll drop in the link in the chat for you to share with you our other educational materials that help families better understand how to manage different symptoms. And we also have a ALS decision tool, which really will pertain to the topics that we talk about today. And then I also wanted to encourage people, if you haven't already, to sign up for the National ALS Registry. It helps you be counted as having ALS, and as well as helping us to better understand risk factors that go into developing ALS. So I wanted to introduce you to Guilia Labarte. She is an adult gerontologist nurse practitioner who specializes in palliative care at Northwestern Memorial Hospital in Chicago. She has over 15 years of healthcare experience with a nursing background in general medicine from John Carroll University, and as well as Chamberlain University. And she completed her master's of science degree in nursing at Loyola. As a palliative nurse practitioner, she is passionate about facilitating conversations regarding advanced directives, goals of care, and coping with life-limiting illnesses and managing distressing symptoms. Dr. John Coleman was born and raised in the South Side of Chicago. He attended Loyola University Stritch School of Medicine and completed an internal medicine residency at Loyola Medical Center. He then went on to University of Pittsburgh Medical Center for training in pulmonology and critical care and sleep medicine. In 2013, Dr. Coleman started his specialty in chronic respiratory failure and was recruited to Northwestern Feinberg School of Medicine, and is one of the two pulmonologist physicians at the Lois and Sully ALS Clinic at the Les Turner ALS Center at Northwestern Medicine, providing respiratory care and support for people living with ALS. In addition, he serves as the head of the Les Turner Support Services Committee and is on the board of directors of the foundation. Dr. Coleman has several publications and has given international talks on proper respiratory care for people living with ALS. So welcome. I am going to turn myself off camera and let you go ahead and take over the presentation. So there you go. Go ahead, Jessica.
Awesome. Thank you so much. Very happy to be here. I'm trying to get my, there we go. Sorry. So I'm Guilia Labarte. Like Lauren said, I'm a nurse practitioner. I do palliative care. So advanced care planning and advanced directives are very near and dear to my heart. I'm hoping that we can just provide a general overview of advanced care planning, advanced directives, which includes the 3 documents that we'll be spending the bulk of our time talking about. That's the power of attorney form, a post form, and a living will. I will go into those in much more detail soon. We also want to go over a couple tools that are they're really helpful tools to help guide the conversation. You can get these online and help have these conversations with your family and your healthcare providers. And we will also cover sort of when to consider these things, like when is it the right time to start doing these documents and doing this planning. Oh, next slide, please. Thank you. So advanced care planning it's this umbrella term, really, and it includes advanced directives. Advanced care planning is a process that helps you make plans about your future medical care. And this is done through a lot of self-reflection, a lot of question and answers, like getting information from your doctors, having discussions with your physicians and your nurse practitioners, having discussions with your family members, and sometimes spiritual and religious people in your life that are helpful in guiding you and your family through tough times. It provides basically a structure for your family and medical teams to know or have a sense of what you would want in the event that you weren't able to say them on the spot. Specifically what you would want and not want. So it kind of gives you a voice even when you don't have a voice of your own due to advanced illness, and it protects your wishes from people not following them. Next slide, please. Okay, advanced directives. So we're going to spend a lot of time on this slide, but we will also go through each document, not word by word, but just in a general sense to kind of familiarize you with these documents. And just to kind of like drop breadcrumbs for you to start thinking about things that you would want or not want before you even put pen to paper with these things. So advanced directives, there's typically 3 legal documents under advanced directives that we encourage our patients of really any age over 18 to consider. Power of attorney for healthcare or medical power of attorney, durable medical power of attorney. I'm sure you've heard a lot of these terms. They're all referring to the same document. And this is a document where you name someone who you trust to make decisions, medical decisions on your behalf if you ever become incapacitated and can't decide these for yourself. Physician order for life-sustaining treatment, aka the POLST form. These are ones that maybe are less commonly heard about. I know power of attorney for healthcare and living will are sort of common terms. This one's a little more robust and a little less known. So it kind of digs, there's 3 different sections. We will go over each of these. I'm just giving a brief overview right now to familiarize you guys with the terms, but this is a more robust section where it really just fine tunes a little bit more clearly, like different from the power of attorney form, different from a living will. This really gets into a little more nitty gritty of what you would want and not want, what you would find acceptable and what you wouldn't find acceptable if something bad were to happen down the road. The living will also does this, but it's very non-specific. And you'll get a sense for what I mean when we start going through the documents. So why don't we move on? Thank you. Step ahead of me. Great. So we're pulling up the power of attorney for healthcare form. And there's a slide at the very end of this presentation that has a list of all of the links that you can go to get to each of the documents that we're going to be talking about today. And I'm hoping we can share that with you somehow at the end, if either maybe by email or some other way. But if we can scroll down, keep scrolling. Right there. Perfect. Thank you so much. So the power of attorney for healthcare form, again, it's important to know that if you don't have a power of attorney form, and I can only speak in the state of Illinois because that's where I practice and that's what I'm familiar with. So this may vary state to state. I'll put that disclaimer out there. But the power of attorney for healthcare form it's very important to have this even before you ever need it, or at least start thinking about who you would want this person to be. And this is someone who you would trust to make decisions that are in line with your wishes. That would be your mouthpiece, so to speak, or to speak on your behalf, and who felt that they could uphold your wishes even if they were tough. So it's important. It's not always the I don't know how to say. It's not. There's like not one right person for anyone. It's not necessarily your spouse. It's not necessarily your parent or your adult child who is also a doctor. It can really. This is such a unique thing that you really need to give some thought to. Who will carry out my wishes, no matter how hard it gets, no matter if they have differing opinions, kind of a thing. You can only appoint one power of attorney, but you can add up to two successor agents. And these successor agents are people that you would also trust, similarly to what I just described for the power of attorney, but they're sort of your backup. Just in case, out of an abundance of caution, that your power of attorney is maybe also hospitalized or incapacitated in some way. These things do happen, so it is good to have a backup person just in case, and sometimes even two people. And if you put more than one name on the power of attorney agent, like that main line, if you put more than one name, your document is actually legally void because it was filled out wrong. So just something to think about, because I see this all the time where people are like, oh, I want both of my siblings to be, my decision maker. You have to pick one, and you have to put the other one as a successor, unfortunately. And yeah, and if we can go back down, actually, I'm so sorry, go up a little bit. I apologize, I'm gonna be so annoying with that. Go up a little bit more. Okay, so name, address, phone number, and then yes, can you go down a little bit more? Sorry, this is so small on my screen. Yeah, and you'll see a lot of this text is really good for you to read. Like once I show you where to get these forms, to spend time with this document. And this is just things that help kind of tease out or get you thinking about who you want. The next section is not who, but what do you authorize that person to do? And there are some, again, these are very general categories, but a little more specific. Do you want them to make decisions for you now, like starting right now, because you're worried that maybe, you're finding yourself to be, not up to task, or not able to, for any reason, either physically, emotionally, mentally, not able to kind of act on your own behalf? Do you want them to decide for you now, or do you want them to only step in and be allowed to make decisions for you once you're deemed to not be able to make a decision for yourself? Let's say you had a UTI and you were very confused for a matter of days or something. There are so many ways that this can happen, but again, just being prepared ahead of time goes a long way. If you can scroll down a little bit. A little bit more. Right there. Great, thank you. So this is where, and again, we're going to talk about the pulsed form next, and you'll see sort of what I meant when I was saying the power of attorney form and the living will do have a section about general things, but it gets a little more robust in the pulsed form. So right here, this section, you're talking about quality of life versus length of life, and kind of which is a little more important to you. It gives just a very general guide to your family and your loved ones. I'm sorry, your physicians, about what's more important. Some people, there's extreme, there's no one size fits all with this. This is a very unique, all of these things are very unique, and one thing does not apply to another person. It's such a personalized thing, and it's hard to think about sometimes, but is the quality of life more important than the length of my life, or is staying alive more important to me no matter how sick I am? That's it. So it's like a kind of a pick one or leave it blank situation. If you leave it blank, it doesn't really help the power of attorney and your doctors, but it's still, at least this document names who we want making your decisions. Can we slide down, please? A little bit more. Okay. This document, unlike the other two, needs a witness. And so it needs a witness that is over the age of 18 and is not related to you in any way. They are not your blood or marriage relative. They are not your healthcare provider, nurse practitioner, anybody. So usually a friend, or even it can even be a nurse or a medical assistant at the clinic or wherever you are when you're filling this out. But you do need someone with no relational ties to you to witness this. If we could scroll down a little bit. And that, oh, I'm sorry, the end is just where you can put your successor agents, your backup people. Okay, that's power of attorney. Just again, very general overview of it. If we could go to the next one. So this is the physician orders for life-sustaining treatments, or POLST, P-O-L-S-T. Again, this is also, and I apologize, I only have the Illinois forms because that's where I practice, and that's where quite a few of the folks that are on this are from. So I apologize, I don't have other states or anything like that, but we will have resources for you at the end to find these two.
And I dropped in the chat the national directory of POLST, so people can look for that.
Perfect. Thank you so much. So this form, this kind of gets down to the nitty gritty. It gets a little jargony. I will be honest. There's a lot of medical jargon, especially in section B, and we'll see that in a minute. But this is also, it's such an important document. Even if you're not ready to fill it out or you have no idea what you would check, it's one that if you can get your hands on it and just sit with it and think about it, it will go a long way to protect you and also help your family and whoever your decision makers are, including your healthcare team, get a clearer sense for what kind of care should they be giving you if you can't tell them. So section A, B, C, and D. Section A is very straightforward. It's and I do want to say I apologize in advance that I don't want to take the humanity out of this. I do want to provide information. I do want to go through these things. These are hard things to think about and to talk about for a lot of people, and it can really be emotional. I want to be sensitive to that. And I can't see your faces or hear anything, so I'm not getting any social cues. So I'm just going to go through this in sort of a very informational step-by-step way, and I hope that's okay with everybody. So section A, again, this is in the event your heart were to stop, right? Regardless of circumstances. If your heart were to stop, do you want EMS, family, do you want people to try to restart it? And that's through chest compressions. And it's a yes or a no. There's no jargon really involved. But that doesn't make it a simple question. The next step kind of takes it a little further up until the point of someone's heart stopping. To what level of care and intervention would you be okay receiving, right? So would you want, there's 3 options within section B, and it's full treatment, selective treatment, and comfort focused treatment. The first one is, kind of, you want everything done. You are okay with going to the ICU. You are okay with invasive procedures to extend your life, such as a breathing tube, a ventilator, chest like all of it, the works. This is not chest compressions, I take that back. It depends on what you answer in section A. But basically, ICU full works, all of the medications, all of the machines trying to keep you alive. Full stop. The middle one is where, yeah, you want to be kind of, you want a fighting chance. You want them to try things. This is where it gets really gray area, and it's so unique to everyone because it's like, yes, but. The first one is yes, just do all of the things. The second one is yes, but hold on a second. I don't want that. This is where you can kind of cherry pick, like, I want to give this a good try, but if it's going this way or that way, and I don't want that ever, this is where you can kind of outline that. And there's in section C, you can handwrite some other things in there that are important to you. The third option under section B is comfort focused treatment. And it is kind of what it sounds like. It's where you say, I don't want any of those things done to me. Given what I've been through, given where I'm at right now, if I were to get very sick and I were facing a hospitalization, an ICU stay, machines, all the invasive procedures, I'm going to say no, thank you. It's not for me anymore. I don't want that. And I just want the focus to be on my comfort. So that's kind of the breakdown. Again, this is a general overview. I could spend literally an hour talking about this one document with patients, especially if it's like an open forum for questions. So I don't want to shortchange you, but I do need to be mindful of our time. But that's section B. It's a big section. Section D is also tricky, but more clear cut. It's kind of, it's talking about nutrition, medically administered nutrition to be specific. And this is, would you want artificial nutrition and hydration to keep you alive? And this would be administered through tubes, either tubes in your stomach or tubes in your veins. And if so, it's like kind of a yes, no, and then if so, do you want a trial period or is it more indefinitely? Below that is where you would sign it. You don't need a witness for this. You do need a healthcare provider to officiate this. So you go through this with whoever. It can be a nurse practitioner, a physician assistant, or a medical doctor, and you go through this together and verify that this is indeed your wishes, no one else's wishes, and you both sign and date it. If we could go down a little bit. And this section, this is an optional section. For purposes of today, I'm not going to go through this. It's something that you can read on your own. So if we can go on to the next slide. So that's the POST form. Again, there's a lot to it. Very important, very helpful tool to protect what you want and don't want, and to give a guideline for people taking care of you. The Living Will Declaration form, again, this is in Illinois. We can click there, thank you. So this is not as robust as the last document, nor the power of attorney document for that matter, but it does kind of have the same focus as that little section where you had to select between quality and quantity on the power of attorney form. This is it's short, we can read through it. If at any time I should have an incurable or irreversible injury, disease, or illness judged to be terminal condition by my attending physician who has personally examined me, I'm trying to find that one-liner that's really summarizes it. I think it's that second paragraph. In the absence of my ability to give directions regarding the use of such death-delaying procedures, it is my intention that this declaration shall be honored by my family and physician as the final expression of my legal right to refuse medical or surgical treatment and accept the consequences from such refusal. So this is in basic terms a way to protect yourself. If you were to get very, very sick, you're at the end stage of whatever advanced illness it is, you do not want invasive measures done. You do not want artificial prolongation of your suffering. This form protects you from that. Next slide, please. Okay, so there are, oh, if we can actually go back to that last slide, I'm so sorry. Thank you. So there are a lot of tools out there that help, a lot of websites. You can Google all of these things. I put the two that I'm most familiar with and that are utilized the most by patients in a clinical healthcare setting. I can't vouch for the other ones. I'm sure they're lovely, but I wanted to put these two out there because I do think they are very helpful. These are both, and we'll go to each website just to give you like a quick overview, but and this ties in also with the next kind of segment of our talk today, which is, you know, like how do I even wrap my head around this? How do I talk about this? Who do I talk to about this? What do I tell them? You know, these documents really help structure the thought process, structure the conversations, and give you some guidance as to how to go about this. We can go to the first one. Thank you. So 5 wishes, you know, feel free, you know, on your own to Google 5 wishes. I think it says in this box down here, the nation's only national advanced care planning program. I can't fact check that. I'm so sorry, but I can tell you that this is a very helpful website, and it's very clear. It's easy to use. Like it's pretty intuitive, which is what I like about it. I'm not tech savvy, so it does talk about these documents that we've already talked about more in depth. It gives you just kind of layman terms breakdown of what you want to think about with each one as you're thinking about it. So I am a fan of the 5 wishes, and I have heard anecdotally from my patients who have used it that they find it helpful. If we can click on that next one, the conversation project. Great, thank you. And this one, I use it less often. I often recommend 5 wishes, but I've been increasingly hearing that this is popular and helpful. If we can scroll down a little bit just to give them a sense for yeah, scroll down a little bit more. So they have these free guides on the left. I'm pointing at my screen like you can see what I'm pointing at. Conversation starter guide, guide to choosing a healthcare proxy. Oh, sorry. We can just, yeah, scroll down a little bit more. So there's a guide to choosing a healthcare proxy. There's a guide to being somebody's healthcare proxy. And then there's a guide for talking with your health team. They also on the right give you a bunch of resources in the community, in the faith community. I do think they set you up with it. I think they also offer I don't know what the term now is, not a chat group, but you know, like a focus group that talks about these things. You know, people that are kind of in the same boat that might be having the same questions. Okay, we can wrap up this one. Thank you. And then, so those are the tools. And again, we're going to segue into when do you consider advanced directives? And this is my own personal opinion, I think as a whole, our society, our country does not highlight these enough. And I think it's something that, when I was in primary care practice, anyone that was over the age of 18, whether they were super healthy, super sick, or anywhere in between, I would bring this up and encourage them to think about it, because you can be 18 years old with no chronic medical issues, and something can happen very quickly. Or you can have a chronic illness that has been plaguing you for years and years, and it's getting worse, and now you're at a point where you're like, do I need to think about these things? So my position is anyone over 18 years old, or 18 or older, regardless of health status, but especially if you have an advanced or life-limiting illness, I would encourage you to at least start thinking about these documents, if not filling them out soon. So I'm going to hand it over to Dr. Coleman.
Great. Thank you so much, Julia. I thought you did an amazing job, and I agree with everything you said. So I am a pulmonary critical care physician. I have trained, I take care of people living with ALS. I take care of people living with muscular dystrophy. I take care of people in an intensive care unit. Ironically, when I was younger and trying to pick the path that I wanted to go down, I stayed away from a bunch of different fields because I was kind of like, oh, you know what, that seems kind of sad, or there's a lot of different things that can go wrong in it, and I didn't feel like end of life care was something that I felt comfortable doing with. And I've since grown into someone that realizes end of care life and advanced care planning is so crucial to everyone every day. It is one of the most selfless things a person can do. And the reason I say that is because I see so many people at their end of their life, especially in an ICU, and their loved ones and their families struggle to say, you know, what should I do in this situation? But if you've already had this conversation, it takes so much of that stress and anxiety off your loved ones, because you've said, this is what I want, right? And as the physician treating your family, your loved one, and as the power of attorney treating your loved one, we're all together, and we don't have to debate or question things. It's, as Julia kind of alluded to, in society, we spend time where we plan vacations, we plan parties, we put all this time and effort, we research things, but when it comes to end of life care and advanced care planning, people don't want to talk about it. And it can really change the course of your disease and the end of your life. And so as a ALS doctor, you know, I think talking about advanced care directives and having those conversations with your family and loved ones, wherever you are in the stage of the disease, is empowering, because then you are saying, I have control over this, right? It's also super crucial for people, especially living with ALS, to have these conversations, because I will pull behind the curtain here and show you there are a lot of doctors that don't understand this. And it gets confusing, and you would think, oh, well, they're a doctor, they should understand this, but there's so many people that also, as physicians or healthcare providers, don't feel comfortable talking about this, and then it leads to stress and anxiety for everyone across the board. And so having these communications is just so important. And what I will say is that through the course of our life, what we want changes, right? So these documents are a little bit fluid, and that's why it's important. What I may value today may be different that I value in 10 years, 20 years from now, right? Or what you may value at the beginning of your diagnosis may be different than what you value at the end of your diagnosis, or when you're more advanced in your disease. In medicine, we can do a lot of things, right? We can do a lot of interventions. What is the result of that intervention? And it goes back to that bigger question that Julia kind of alluded to, which is quantity over quality, right? We can do a lot of things that can keep your body alive, but what does that signify, right? And that's personalized for everyone. And what one person may think is a valued life, someone else may think not. And so we are not here to pass judgment. We are not to make that judgment. We are there to support you on your process. I will say, going back to the pulse form, and I'm not going to make Lauren go back to that, but that middle section is super gray, right? That B section, where it's like I call it the a la carte section, right? It's kind of like, I want this, but I don't want this, but I want this, and I don't want that. One of the questions that I get commonly asked as a pulmonary physician and taking care of people with ALS is about intubation, right? Is it right? Is it wrong? And I always phrase it in the sense of, I think it has a role in certain situations, right? So if you are kind of living your life with ALS and having your progression, but you get a flu or you get a cold or you get an infection, I've always said, in my opinion, it is totally appropriate to pursue something like an intubation for a time limited trial, right? So like, hey, we're going to put this breathing tube in. We're going to see if we can give you some antibiotics, clean you out, and then try to extubate you. But if we cannot get back to something similar to the quality of life you had before, what would you want long term? And where does that come into conversations about like long term mechanical ventilation? That B section is like, I don't want anything. And I think that's why it's so important to have a healthcare power of attorney that understands and can be your voice in that situation, that says like, hey, we want to give everything a try up until this point, but we don't want to go down that road. And I think that helps your healthcare team, it helps your loved one, and it helps and everyone's just speaking in your voice, right? So when to consider advanced directives, and I'm going to speak specifically for people living with ALS because that's the situation I'm going to talk about today. A lot of times it can be based on your clinical symptoms, right? So like, is your eating getting worse? Is your breathing getting worse? Are you having more pain or discomfort? Is communication getting worse? The things that give you self and give you quality, are those things getting worse? And as your provider, it is my job to kind of inquire about those things, but it's also, I need you to tell me because I can't foresee. And one person, the person living with ALS may downplay it, and the people caring for them may be like, oh no, that's way better. And how is everyone perceiving the situation? We can't make these decisions in a bubble alone, right? So like, there are people that love you, and there are caregivers that are invested in your life. And so when we're starting to make these decisions, it's important to have these conversations, because you want to make sure that everyone understands why you're thinking this way and values, and that makes it easier for them when they have to be your voice. And like Julia kind of alluded to, when should you have conversations about advanced directives? Anytime, even if you don't have ALS. I have conversations about this all the time with my spouse, with my parents, and they're all in different stages of health, because I look at it and I see what end of life can be like for a lot of people, and I'm just trying, probably selfishly, to be protective, right? And then be like, how can we make sure we honor you? And one of the hardest things is people always say like, well, you'll know what I want, right? And that's so hard because we can't make decisions without our own personal bias. And so we start thinking like, well, this is what they would want, or is that what they want, or is that what I want in that situation, right? And so having these conversations really is, like I said, one of the most selfless things you can do. Next slide. Okay, so how to bring up advanced care directives with your treating healthcare provider. In the case of ALS, I will say that majority of your physicians should understand that this is a terminal disease, and that end-of-life care is part of how we should be treating you, right? It's something that we have to think about. So don't be afraid to ask. Your physician is on that path with you, or your healthcare provider is on that path with you, right? So like, from the time you're diagnosed through your progression of your disease, we're only looking out for what you want, right? ALS is a disease that takes away independence. It takes away decisions. But end-of-life care is a decision that no one's going to take away from you, and that's why I want to be very clear to have those conversations. So if you say, I don't want this or I don't want that, I never pass judgment, and your healthcare provider should do their best to not pass judgment, but to be supportive and be like, hey, I am here for whatever you want. I'm not living in your body, so however you see the situation, I'm going to do what you're asking me to do. Asking about thoughts on progression, right? So I always get questions about like, well, how am I progressing? And one of the things that we do at our center is we do breathing tests, right? Which is a huge stress for people coming in, right? They're like, what is the breathing number going to be today? What is this going to reflect? Oh my God, am I getting worse? I think I'm getting worse. Am I not getting worse? And what I always say about that breathing number is that is one picture in time, right? So like, you could have a bad day. When you come to see us at clinic, you could have gotten stuck in traffic for 3 hours. You couldn't find a parking spot in the garage. You could have been, moving around a ton. And then you come into the clinic, and we we rush you upstairs and we say, okay, now breathe, and we're going to test your breathing, right? And it may just be a really crappy effort because you're just tired. And so I always say, like, well, you know what? I always like to see several pictures in time, right? And see where it goes. And because we can't tell where you are just on one picture. Now, there's other symptoms that may tell me things like, oh, I'm getting more tired, or my voice is getting weaker, or I can't eat as much. And those are kind of how I ask questions to assess where you are. But it's always good to kind of not put a lot of stress on this stuff, but have that conversation. Because your healthcare provider should know you in a longitudinal relationship to assess where you are in things. And then asking about how to prepare and what are common symptoms at the end of life, right? So people are always scared of choking to death, whether it's on nutrition or whether it's on they can't breathe and gasping for air, right? And so how do we treat those symptoms? You know, in my case, sometimes we treat people with BiPAP machines, and sometimes people choose not to have a BiPAP machine, and that's fine. But my responsibility is to make sure that you don't have that fear at the end of your life of choking or suffocating, right? And that is part of medicine. That is just as important as intubation and vasopressors and dialysis, is making sure end of life and transition is treated appropriately. Next slide. Okay, so helping patients, families, and caregivers make informed decisions about advanced directives. Well, I think Julia kind of went through a lot of really good points. So I think having some paperwork to guide you, having the 5 wishes to initiate those conversations is really important, because nobody wants to start that conversation. I can't tell you how many times even I try to have that conversation with my own parents and be like, my mom's like, not today, or sometimes, well, we got to do it at some point, right? You know, and so I say I'm not trying to be, you know, looking at the downside, but like we have to make sure that I know what your wishes are. So honest and open communication, and it is, like I said, it's planning to take care of someone in the future and not putting that stress on your loved ones. Be true to yourself and what you value, right? It's so hard because we don't, like I said, live in a silo, and we're so intertwined with our family and our caregivers that people hold on because they're like, well, I got to do this for them, or I got to do this for that, or, you know, I got to finish all this paperwork. Everyone always, at the end of life, everyone has a lot of paperwork they always have to do. And I want you to be clear of like what is important to you. And what I say to patients, and I think this has always worked, is the right time to think about this stuff, or the right time to really transition is when do the bad days become more than the good days, right? So like we all have bad days, we all have good days. When they're one-offs, we can tolerate things, right? You know, like a bad day here or there, we can tolerate. But when more days are bad than good, it really is a point to be like, okay, well, where am I going, and what do I want, and what do I value? And so that's how I kind of phrase it when I have conversations with the people I care for, is when you feel like you're having more bad days than good, is this the time to really focus even more on your end of life and comfort care, right? So that's kind of my perspective of it as an ALS provider. I know that there were some questions that were submitted earlier. I don't know if, Lauren, you want to ask those questions, or I have some of them as well, or I don't know if people added questions to the chat, but Julia are here both to kind of answer your questions. Today was just about some very big broad strokes and educating you on what advanced care directives are, as well as how to have those conversations with family.
Great. That was really helpful, Dr. Coleman and Julia. That really helped walk us through a little bit. But you just talked about all these documents. Where do you put them?
That's a great question. I would encourage you to keep them in a file in your home. If you have a post form filled out, I would keep a copy on you at all times if possible, and even maybe keeping one on the refrigerator, which I realize sounds kind of morbid. It's like, oh, let's have our cup of coffee. Yep, there's my post form on the fridge. But it's important, and I say the fridge because, you know, if something were to happen and you were to, let's say, pass out at home, and no one was with you, and a very nice neighbor sees you through the window and says, oh no, I'm going to call 911. 911 busts through the door to save your life because that's what they're trained to do. If you don't want that, right, if that goes against your wishes, like if you were laying there without a pulse and they brought you back and you had a pulse form on the fridge saying you didn't want that, it's a protection. It's a protection, and it's putting it in a visible place, because that's often where the EMS people will look, just in case. And then having one on you in case you're out at dinner, you know, something happens, you're feeling a little lightheaded, I think you need to go to the emergency room, you're out of breath, you just hand them the form, just they can put it in your chart, and it saves a lot of conversations, and it saves a lot of repeating yourself over and over anytime you're in a new situation.
I will also say with technology, you could probably just take a picture of it on your phone as well.
Mm-hmm.
So you don't always have to have that piece of paper in your back pocket that's your pulse form. But I think the fridge is a great idea. I think once you complete a pulse form at your visit with your physician or healthcare provider, having them take a copy of that as well and scan it into your chart. You know, obviously, if an emergency happens, you always go to the closest hospital, which may not be the hospital that has a copy of it on record. But the more places you have it, the better it is. But taking a picture on your phone is a great spot as well, because you can just, you or your loved one can pull it up and be like, here's my healthcare power of attorney. Here's my pulse form. That just makes things so much easier for your health team.
Yeah. And I know our team often talks with families about, you know, putting it in a bag so that way they have that, you know, if they're heading to the hospital, you know, to have that. So I think making sure that everyone is aware of where that's at is really important. And, you know, if you have caregivers, to walk them through to make sure that they understand what your needs are too. So Dr. Coleman, you talked a little bit about BiPAP, and like I can see where that would get confusing in the pulse section. Like, what is comfort measures for you know, how does that pertain with the Illinois Pulse and use of a BiPAP?
Yeah, so when you look at that pulse form again, like that B section says you can use BiPAP, and BiPAP is it falls under that selective treatment, and I think what's really important is to know what is the situation you're using it in, right? So there's acute and there's chronic, right? So people come into the hospital who may not ever be on BiPAP and they need to go on it acutely. And I think that may be a selective therapy that they need to use in that situation to maybe prevent mechanical ventilation or intubation. Then there are people who have it chronically, right? So people living with ALS may be on BiPAP at night. They may be on BiPAP some parts during the day. And they're using that more and more as their disease progresses, because it is a therapy that maintains them. So it's providing them comfort, but it's also an intervention. And so I think it falls under that category of B. Like if someone were, when I think about in terms of people living with ALS, and I think of option C under, or part 3 on the section B, which is comfort only, you can use BiPAP in that situation, but more so than not, you're using it in combination with like morphine or Ativan drugs in that situation. Because if you take someone off BiPAP machine at the end of their life, they're going to really struggle. And so that's why BiPAP has always even been covered by hospices. Like hospices don't come in and say, oh, you can't have BiPAP, because they understand it is used for comfort, especially at the end of life.
Thank you for that. That's really helpful. And just as a reminder to the audience, we have a decision tool to help people make decisions about non-invasive ventilation or BiPAP that they can work through and learn a little bit more about that as well. Julia, what do you do? And one of the questions that came in, they use the term reluctant patient, and I think it's that maybe, you know, we face this all the time, right? Where a person living with ALS doesn't want to face or make some of these decisions, and you know, causes a stress in the family. And this, you know, how do you work with families to help them understand, and how do you work with that reluctant person to fill out the forms?
Yeah, it's a great question, and you're right. It's something that comes up very often, and I think it's it's such a sensitive topic, and I think it is so, it can be, for some of us, it can be, oh, this is a great way, I want to do this. Like, I'm a planner, I want to get things all lined up, I want to have this, I don't trust so-and-so to say this, I want to put it in writing just to cover my, behind. And then for some people, it's literally a shutdown of like, I can't think about this. This is too hard. This is what, like, it's all I can do to get through my day sometimes. You want me to like plan all of these? No, I can't. And I think giving people grace with that, and it's counterintuitive, especially I know as a loved one, you're like, I just need you to fill these documents out so I know what to do for you. And you can't, it's like, there's this like fear, this desperate need to like get these things in line from the relative side, which is understandable. But then there's this understandable, the question calls it reluctance. I say it's fear. And I think giving someone, acknowledging it and giving someone space to not be pushed can sometimes help them have a mindset to start thinking maybe even in their own, and just like dropping breadcrumbs and not having it be this whole formal like you need to sit down and get your affairs in order. It's like just look at the form, and in a week, if you have questions, just kind of the counterintuitive, the more you want to like, come on, we got to do this, that's when you should really try. And it's not easy, I'm not saying it's easy, but try to give that person space and just say, I know this is hard. This is going to be helpful to me. I'm scared that I'm not going to be able to make these decisions for you. And I don't want to do the wrong thing. Like, can you please help me? And things like that. But I do feel, and this is, unique to every relationship and every person and every situation, but I do feel in this particular instance, when it comes to advanced directives, the more you push and push with someone who is, for whatever reason, unable to engage in these things right now, I do worry it has the opposite effect. And so I find myself, even as a provider, when I have a patient where I'm really worried about them, they just get landed in the ER, they're really sick, they're going to the ICU, I've seen these things, and I know this person, I kind of see where we're at in this, and I want to have these conversations, and I want to push these conversations before they maybe lose consciousness or get sedated for a procedure. So I feel that too in that kind of urgency of like, no, we got to do this now. I stop myself, I take a step back, and I say, this is not going to be productive if I force someone, or like urge someone. So taking a step back sometimes and just giving them space, and just start, instead of the big thing, just start with like, just look at this document on your own time in a week when you're ready, glance at it. If you have questions, ask your doctor, and then like kind of just keep going. Okay, well then check the box, Sorry, that was a really mumbled, long-winded.
No, I mean, I think that's really helpful. For me, I think back to, my 20s when my dad had heart surgery and we were, signing the forms and having those conversations, but I can't get him to revisit it, many years later. He doesn't want to have that conversation, and not being able to engage. And I've had to pull back and use humor and try to work on that. And it's definite fear for our families, and it's the reality of ALS, right? And it just doesn't feel good to look at it and think, but you can hold both hope and reality at the same time. And being able to focus on certain things like completing the advanced directives allows you that space to think about other things and get past it, always knowing that you can revisit things again, like Dr. Coleman said. So really helpful. It wasn't meandering at all, because I think that was really good guidance for all of us, because sometimes you think things are checklists, and they're not, right? These are lives, and people who are have a lot of questions and better understanding and need to know, right? Dr. Coleman, what does end of life look like for people living with ALS? What does that mean? And can you talk a little bit more about that?
Sure. So ALS, progressive disease, right? So it affects nerves that control muscles. Most end of life with people living with ALS is respiratory related. It's pulmonary. Their muscles start to give way and they can't ventilate or get rid of that carbon dioxide as effectively, which can't give them the oxygen as effectively. And there are signs that we see as things progress, right? So people may start off with some non-invasive ventilation at nighttime, right? So they wear it at night and they take it off during the day and they can do about what they want to do. And then as the disease progresses, they start to have symptoms during the daytime where they may be getting more fatigued. And so we start kind of creeping in that BiPAP machine a little bit during the day. And then it expands even more. Maybe they need it more during the day for meals. And as it progresses, they get to it on 24 hours a day. And some people can still live for a while on 24-hour non-invasive ventilation. But at some point, even when you're on that, there's limits of what we can do non-invasively. And the question always comes up like, okay, well, when should I think about a trach, right? And what I tell people about a trach versus non-invasive ventilation is we're basically doing the same kind of ventilatory support. We're just changing the method of the way the ventilation gets done. So a tracheostomy is a surgical tube in your neck where air is going in and out and ventilating you, whereas non-invasive ventilation is a mask, right? But the settings on the machines can be very similar sometimes, and so you don't always gain a whole lot by going down the road of a tracheostomy. But end of life is going to be more short of breath even on your BiPAP settings, or more you can't come off of it as long as you used to in the past. And when that starts to happen, I try my hardest to have stepwise therapies for people at home, right? So they're on something like 24-hour non-invasive ventilation. They may be on a home mechanical ventilator through non-invasive ventilation. And I give them stepwise up. So like if they're feeling short of breath on this setting, they can go up a setting during that day and see how that feels. I never want them to feel like they're gasping for air. But if they're getting to the point where they're constantly needing changes in their vent settings, I think that's really important for me to understand that this is a time where we also need to make sure there are other therapies in the home, like morphine or Ativan, to help treat those symptoms when the non-invasive ventilation can't do that.
And that's when hospice can be so helpful in guiding the families and supporting and having those conversations, all along the way.
And I want to make this point. I know we're getting close to the time, but hospice has a very negative connotation in America, right? So people think, of hospice in terms of cancer, and they think of, okay, I know so and so, they had cancer, they went on hospice, and they died 2 days later. That is not necessarily the case for people living with ALS. Hospice is a type of care that focuses on your comfort, and the earlier you start it, the more you can get from it, right? The more you benefit from that service. It's not just there for like those last 48 hours of your life. It's there to help make sure that the time that you have left is comfortable. And so they have, Julia could probably speak to this more than I can, but they make sure that they have, people that can help bathe you, or there's other services, and you have a nurse that checks in on you. When you go on hospice, it doesn't stop your ability to come see me in clinic, right? So like, I think that people think that when we talk about hospice, we're just giving you up and putting you to the farm. We are not. We're just making sure that we're covering all of our bases to make sure that the quality of your life is the best it can be.
Julia, do you have anything to add to what Dr. Coleman said about hospice and palliative care?
Yeah, no, I agree with everything he said. And it's just really a source of support. And I think, I get asked this all the time, even from some clinicians, where it's like, what's the difference between palliative and hospice, and why should I do one or both or either? And I always, kind of my nutshell explanation is palliative care and hospice are on the same spectrum, and they're both providing support, guidance, symptom management, and resources tailored to what you're needing. And sorry, that was my dog, I apologize. If palliative care is an extra layer of support regardless of how far along a disease process is, what your prognosis is, how aggressive or not aggressive you're trying to be with your care and with prolonging your life. That's palliative care is given anytime, as long as you have it's usually given with a life-limiting illness or an advanced disease, right? And then we also help people along the way, and we help identify like when is it time for hospice. And I get that, like, how do I know if hospice is right? Is it the right time for hospice? And you know, I often say it's when all of our when you're suffering and you're having more bad days than good days, refractory to palliative care and interventional care and all of these things. And we've kind of run the course of what palliative can offer in the home, you know, for symptom management and for support. And let's say often the person says, you know, like, I've been hospitalized 5 times in the last 3 months. I just want to be home. I'm sick of this. I don't want to do this anymore. I look at where I've been, I look at where I'm at now, and as I look to the future, like, I just want to be kept comfortable in my whatever place is your home. And sometimes people prefer a skilled care facility because they have more nursing needs met. But wherever it is, you can get hospice and or palliative care, and that's kind of, yeah. But they're along the same spectrum. It's just hospice does tend to be, I know a lot of people have heard it's the last 6 months, or if you have an expectancy of 6 months or less. You do have to qualify for hospice. You can't just say, meh, I'm going to go to hospice. I wish it was, you know, I wish they didn't have, because I do agree with Dr. Coleman where it's a very, very supportive service. But you do have to be qualified by it. Yeah.
Well, thank you so much. We're running short on time, but I think, you know, this really helped, you know, clarify some of the forms that are available, where to keep the forms, starting those conversations, learning to stop those conversations if necessary. You know, I think we're really, we have a lot to learn from people living with ALS and what their experiences are. And I would welcome everyone to join us on May 30th. We're going to have an expert from Australia, Anne Hogden, who is a pioneer in better understanding how people living with ALS make decisions. And so she'll be sharing some of her data, and I think families could really get a lot out of that, hearing firsthand from people living with ALS about what their experiences are through her research. Again, thank you so much, Dr. Coleman. Thank you, Julia. I think it's just really helpful for us to have these conversations. We'll make sure the slide deck is also up on our website, as well as the national resources for folks. So I just really want to thank everyone for joining us today, and I hope you have a good day. Take care. Thank you.
Thanks, Lauren. Bye.